morning, everyone. So I'll spend the next 20-25 minutes talking about pseudo lesions of the liver. You've heard from Karthik how a cirrhotic and even non-cirrhotic livers land up having all kinds of lesions, and it's important for us as radiologists to differentiate those lesions which need attention versus those that need to be left alone. And since a lot of us use a lot of imaging modalities on a routine basis, a lot of these patients come for CT and MR based on an ultrasound diagnosis of a lesion in the liver. So a definition of a pseudo lesion is an abnormal area of parenchyma mimicking pathological lesions. The causes of pseudo lesions in the liver could be parenchymal, could be vascular, and there's a subset of other etiologies which can occasionally confuse a radiologist whether he or she is dealing with a pathology or not. The parenchymal causes, commonest are of course focal fatty infiltration and sparing, which I'm sure all of you are aware of, and I'll show some examples of that. Then there are conditions such as segmental and focal hypertrophy, confluent hepatic fibrosis. With newer imaging techniques, we are seeing less and less of parenchymal compression in the liver leading to pseudo lesions. This used to happen in the early days of the CTs, and I remember Dr. Hagar's early books had a lot of stuff about parenchymal compression, especially from ribs. And then there are two entities, peliosis, habitus, and inflammatory pseudotumor of the liver. Amongst the vascular causes are THAD and THID, vascular malformations. Quick demonstration of how we do our CT scans. We use typically approximately 100 ml of high concentration contrast. We put the cannula in the peripheral antecubital vein. You have to use a high flow of contrast. One of the reasons why I'm showing this slide is one of the mistakes often made in radiology departments is to get the correct delayed arterial phase of enhancement. And when we use the threshold for a care bolus technique, most CT scanners have a default setting of between 5 and 6 seconds after peak contrast opacification. And it's important for all of us to remember that if you are looking for a late arterial phase, you have to wait for an additional 6 to 8 seconds after that 6-second delay, which means if you're putting 100 HU as your threshold value, you should wait for approximately 12 to 16 seconds after you achieve that threshold value to get a delayed arterial phase, which is where you will pick up the hypervascular lesions. Of course, the venous phase is approximately a minute after contrast injection, and then you can take the delayed phases afterwards. So a typical example of a hemangioma demonstrated previously by Karthik as well. On the MR, there are a lot more sequences that come into play. You use a combination of T1s and T2s using various breath hold techniques, single shot techniques, and then you use the pre and post contrast 3D sequences which have different names and different scanners. But typically this is what your post MR study looks like. You have at least 12 to 14 sets of images. These are a combination of single shot techniques, the haste and the true FISPs. These are T2 weighted scans, the haste and the routine TSE T2. You have to have an in and opposed phase in any abdominal imaging. That's like pretty standard, and that's what is going to be the key sequence for you to pick up a lot of the pseudo lesions that I'll talk of. And then you have the lesions with FAT-SAT, you have the diffusions and the ADCs, and these are the post contrast studies. And this here is the delayed scan, and you can see that the liver parenchyma in the hepatobiliary phase actually shows a much greater enhancement than the parenchyma in one of the earlier phases. And this is something you need to be aware of when you are looking at patients with focal lesions, because the liver parenchyma tends to enhance sequentially after intravenous contrast. If you do use a hepatobiliary contrast, while the 60-minute image can be of use to you to distinguish some of the lesions, the problem actually comes in the immediate delayed sequences, which means, like Karthik showed earlier, you saw some patients had delayed scans at 5 minutes and 10 minutes. And if you're looking at a certain subset of lesions in that window, you may in fact have a conflicting result. You all know that hemangiomas take up delayed contrast in 5 to 7 to 10 minutes. But if you're taking a patient with hepatobiliary contrast, you will see that the rest of the parenchyma also enhances. So while this is not so problematic for larger lesions. For smaller lesions, you have to be pretty sure that you don't use the hepatobiliary contrast agents, because this window of 5 to 10 minutes may actually be conflicting rather than not, because the liver parenchyma also tends to enhance. So moving on to the pseudo lesions of the liver, we'll start with the parenchymal ones. And focal fatty infiltration and sparing are the commonest pseudo lesions that we all come across. And pretty simple switch on and off one sequence of MR, which is a dual echo T1 weighted gradient echo scans, where fat will drop signal on all opposed phase images. Now, I do understand that most of you would know how to distinguish the in phase from the opposed phase, but just as a rejoinder, any sequence where you see this India ink effect at the interface of a viscera or an organ with the surrounding fat is the opposed phase image. So one way to actually first approach a T1 gradient echo is to look at this set of images. Wherever you see the signal drop is the opposed phase. And here is this part of the liver, which on the opposed phase shows this characteristic triangular signal area of reduction, which is in segment 4 adjoining the GB fossa, which is the commonest area of focal fatty infiltration. On CT, when you have fat in the liver, there is reduced attenuation. And here's a multi-phase CT where you can see that the liver on the plane scan shows lower signal than this lesion. And as you go ahead through the various phases of contrast enhancement, this area remains slightly brighter than the rest of the liver, more hyperattenuating, which is an area of focal fat sparing. And that's what it looks like on MR. On the opposed phase, as far as focal sparing goes, the entire liver will drop signal. Just a reminder that this is the opposed phase image, because you can see the India ink effect. And on the in phase, you can see that this lesion is becoming more iso-attenuating to the liver, indicating that this is nothing but normal parenchyma. Occasionally, the degree of fat infiltration in the liver is so high that not only do you drop signal on the opposed phase image, but you will also see a drop in signal on the fat sat images. So here is where patients with severe fatty liver, you will get this area of the fatty component of the liver drops signal greater than you would normally expect in a fat sat image. And the other thing that happens when you have excessive steatosis in the liver is that there is a reversal of the T2 signal of the liver. So I'll go back a couple of slides and I'm going to show you this set of slides. The liver normally is darker than the spleen on the T2 weighted images. But when you have excessive fatty infiltration, the liver actually becomes brighter than the spleen. And I'll show you another example of that. You can have varying degrees of hepatic steatosis. Here's a patient who has steatosis in the entire liver where the segment 4 steatosis is greater. And here is that example where the liver is actually brighter than the spleen, which is actually what should not happen on a T2 weighted image. On a T1 weighted image, the liver is brighter, but on a T2 weighted image in a normal liver, the liver is darker than the spleen. Fatty infiltration can be patchy and geographic. As you can see in this patient, on all other sequences other than the opposed phase, you can see that there is just pretty much a normal parenchyma. Here's a patient with CA breast, came for a CT and there was this lesion which was looking more rounded, and there was a high suspicion of metastasis. But being a common area of fatty infiltration, one did go ahead and do a MR in an opposed phase. We just put the patient into the magnet and just did this single sequence. And what you can see is that this patient has diffuse fatty infiltration. The degree of fat in different components of the liver is different. And this lesion, which was assumed to be metastatic, was nothing but focal fatty infiltration, which was to a greater degree of infiltration than the rest of the liver. This patient was subsequently biopsied, and of course it was confirmed because there was a high anxiety level both with the oncologist and the patient. Moving on to cirrhotic livers, cirrhosis does not necessarily always land up being uniform and involve both the lobes at the same degree, and you will have asymmetric cirrhosis. So here's a patient who has asymmetric cirrhosis with nodules in the left lobe. This can be mistaken for tumoral nodules, especially when the right lobe looks normal. Again, don't have to go too much into contrast in all patients. I will show you some examples of that, but if you use the standard T2s and T1s within an opposed phase, you will be able to see that these nodules are nothing but normal parenchyma. Here's another patient with cirrhosis. You can have issues with diagnosis. if you follow the protocol correctly and you use the combination of sequences that I mentioned earlier on in the slide, you will be able to see that the parenchyma enhances pretty much the same way as normal parenchyma does, but it's just that there is distortion, and therefore you're not looking at any abnormal lesion, but just variations of normal hyperplasia of the parenchyma. A specific type of hyperplasia is an entity called lobar or segmental hyperplasia, where you have enlargement of either a lobe or major part of a lobe in one or many segments of the liver. And where you see one area of hyperplasia or hypertrophy, you will see other areas showing atrophy, and this is called the hypertrophy-atrophy complex. And in these atrophic areas, you will see necrosis or fibrosis, and this condition is commonly seen in two entities. One is Budd-Chiari and the other is primary sclerosing cholangitis. In Budd-Chiari, this is usually the caudate lobe which enhances, and when we look at these nodules, they can be small or can involve an entire lobe. And what you are seeing here are T1 weighted images where you see distortion of the normal liver vascularity, and you see these large areas of normal parenchyma, but towards the periphery you're seeing some loss in signal on these T1 weighted images. We run an MRCP and you can see that there is peripheral pruning of dilated biliary radicals in this patient of PSC. And here is another patient with a more florid form of lobar segmental hyperplasia, where you're seeing multiple mass-like lesions in both lobes of the liver, which are looking like tumorous nodules, and intervening between these are these areas of necrosis and fibrosis, which show low signal on T1, are hyperintense on T2. And when you look closely at this part of the parenchyma, you can see these dilated biliary radicals, which are the etiology of this case, and which is primary sclerosing cholangitis. So when you're doing MR of the liver, if you're a technologist or you find a liver pathology, or as a part of your standard protocol, it's not a bad idea to throw in these single shot T2 weighted MRCP images, because they will be incremental in adding to your diagnostic criteria. This is another entity, confluent hepatic fibrosis, which is often mistaken for mass lesions. It occurs in a significant percentage of patients with advanced cirrhosis. It's usually the medial segment of the left lobe or the right lobe which gets involved by this entity. The areas of fibrosis are hypodense and hypovascular on CT, tend to be low signal on T1, hyperintense on T2, because a lot of fibrotic lesions of the liver also have an inflammatory or an edematous complex, and therefore they show as hyperintensity on T2 weighted images. And on post-gadolinium scans, they tend to show progressive enhancement. And like other serous or desmoplastic lesions, there is a degree of capsular retraction. So here's a patient with what appear to be multiple mass lesions in the liver on the plain scan, which is what was seen on ultrasound. You see this large area of triangular shaped area which is hypodense compared to this, and along with that you can see that there is this step off due to capsular retraction adjoining this area of abnormality. So while these were reported as nodules, it was in fact the reverse, and this patient had normal parenchyma and areas of fibrosis, which on post-contrast images, as you can see on this early arterial phase and venous phase, there is a sequential enhancement of the area of confluent fibrosis. On MR, this same patient shows low signal in the areas of fibrosis on T1 weighted scans. There is a hyperintensity on T2 weighted images because of the fact that there is an inflammatory edematous component, and this is of course accentuated on the fat-sat images, and you can clearly see the capsular retraction as a step, but the contour of the liver is smooth. When we use contrast, there is progressive enhancement, again because fibrosis tends to retain contrast. If we were looking for a focal lesion which had a fibrotic component, you can use purely intravascular contrast media and do not have to go for hepatobiliary agents. When you do have confluent fibrosis, it can also show restricted diffusion. This is a diffusion weighted scan where you're seeing hyperintensities in the area of fibrosis. But what is characteristic is that wherever you have the abnormality, and that is the fibrosis, there is a flattening of the liver contour. You can see it in all the images, including the post-contrast images, that there is a flattening because of capsular retraction and fibrosis in that part of the liver. I've not seen too many of these. This is one biopsy-proven case of inflammatory pseudotumor that I have seen, which is usually seen in children and young men. There's a whole pathology where you have obliteration or it's some kind of vasculitis. You can have symptoms of recurrent cholangitis, malaise, fullness. you can see early peripheral enhancement followed by homogeneous enhancement, but this is again not very specific. The interesting thing is that the T2 signal can be varied, and it depends on the type of histology. And this is the patient that we had seen, where if you look at this T2 weighted image, there is a low signal of this lesion, which is also hypointense on the T1 in and opposed, and it shows this peripheral irregular enhancement with some degree of filling in. This patient did land up going in for a biopsy because we did not make this diagnosis as a prospective diagnosis, and it came up as inflammatory pseudotumor. This is the other condition which I've been chasing for many years. I guess because of the kind of practice we live in, we don't really get too much histopath for lesions which are indeterminate, which is Pancreatitis, habitus. We've tried to make this diagnosis but not really had too much results. So here's one case from the literature which shows this blood-pooled vascular space in the periphery of the liver. Moving on to vascular causes, you have the THAD complex, basically between CT and MR, and the vascular malformations. We all know that THAD is because of portal vein thrombosis. It can be associated with intrahepatic shunts and usually involves either a sector, a segment, or a lobe of the liver. So here's one patient who has portal vein thrombosis, and you can see that there is a hypodensity in the caudate lobe of the liver because of differential enhancement in the portal venous phase. Normally these areas will show greater arterial enhancement. Here's another patient where if you look at this arterial phase scan, you can see that there is adequate contrast in the aorta, and this was a proper protocol done study. But when we started looking at the venous phase and the portal venous and the hepatic venous phase, we found that the liver did not really take up too much contrast. And the reason for that was that this was actually a semi-congested liver because there was hepatic vein thrombosis, which you can see here, here, and here. And as a result of which the liver parenchyma did not really enhance. And the left hepatic vein was relatively spared, which is why you can see that parts of the posterior segments of the right lobe and the left lobe were showing better enhancement. In fact, there was also thrombosis of the splenic vein. And both hepatic and splenic vein and systemic thrombosis can be seen in patients with paroxysmal nocturnal hemoglobinuria, which is what this patient had. He has an HCC with hepatic vein, with portal vein invasion, and you can see that there is differential enhancement of the left and right lobe, again secondary to portal vein thrombosis. You can have differential enhancement of the liver not just due to portal vein thrombosis but due to reactive hyperemia, which can occur both in HCCs as well as abscesses. This is a patient showing an arterial phase enhancing lesion with washout, capsule, which is a characteristic HCC, but what you see on the arterial phase is also a very clear line which differentiates the segment 7 from segment 8, indicating that there is a differential enhancement between both segments of the liver. And here's a patient with a hepatic abscess where you can see reactive hypervascularity, which can lead to transient differential attenuation of the liver. Common vascular causes are arteriovenous malformations, arterioportal and portosystemic shunts, and of course the third flow, which we often see in a lot of patients, especially those on chemotherapy post-oncology treatment. And this third flow basically indicates that there are parts of the liver which have cystic peribiliary or epigastric venous system which has a separate drainage compared to the normal hepatic veins. And when we are looking at vascular lesions, they tend to be hypervascular because they're malformations, and like all other benign lesions, they either tend to remain hypervascular or hyperdense or hyperintense and do not show washout. So here is a small AV malformation here. Here's another patient who has a normal looking liver. On the plain scan, there is no focal lesion, but on the arterial phase, you can see that there is a focal area of enhancement, and it fades like all benign lesions do on the portal venous and hepatic vein phase. And that's the hepatobiliary phase where again the lesion is not seen. This patient also had a prior CT, which the patient was able to give to us after we reported the MR. And the CT, you can see this little abnormal vessel in the center of the lesion, which is also seen on the MR study. And that's the portal venous and hepatic vein phase of the CT, showing that the lesion fades or remains slightly hyperdense to the rest of the liver. Portosystemic shunts, there's a full classification called the Park classification. You have type 1 to type 4. You occasionally see these lesions during a study done for other reasons. And here's a patient who had a right-sided RCC who had come to us for staging. And along with the RCC, there was this focal lesion in the left lobe. even on this non-contrast true FISP image, you can see that there is a draining vein coming from here going into the left hepatic vein, and that's the left portal vein which was actually supplying this lesion. The ultrasound showing the lesion, that's the post-contrast MR showing this lesion to remaining hyperintense on all phases of study, and that's the draining vein and the supplying portal vein in this portosystemic shunt. I've been lucky to see one case of Rendu-Osler-Weber disease, which is basically involves the liver in about 10 to 40% of patients. There are multiple shunts, telangiectasias, and vascular masses in the liver. Usually patients are asymptomatic or can present with encephalopathy, cholangitis, or portal hypertension, and even have cirrhosis. So this is the non-contrast study, and you can see that there are multiple flow voids in both lobes of the liver, which is enlarged, and the liver parenchyma itself is heterogeneous, and you can see these subtle lesions which are low signal intensity on T1, hyperintense on T2. On the contrast enhanced study, there's a more dramatic appearance, and you can see that there are these multiple nodular lesions of varying sizes, and this vessel here is not the portal vein. This is actually the celiac axis, or the hepatic artery branch. This structure here is the portal vein, and because this patient had large arteriovenous malformations, there was marked enlargement of the hepatic artery branches. A little bit about the third flow. Third flow, a lot of you must be seeing a lot of CT scans, and you see this typical hypodense area along the anterior surface of the liver, close to the fissure for ligamentum teres, which is basically an area of decreased perfusion because of hepatic nutritional ischemia. This occurs because this part of the liver actually gets drained by two veins. One is the vein of Sappi and the other is the vein of Burrow, and therefore it should not be mistaken for a focal lesion, especially in patients with follow-up for malignancy. So while this appears as hypodense in most instances because there's normal vascular supply, occasionally you can see hypervascular lesions in the liver, and this was a triple phase CT we were doing for evaluation of a liver lesion, and you can see that there is this marked enhancement of this part of the liver, and the reason why this was enhancing and the aorta was not was this patient actually had a mass lesion and a CA lung, and there was SVC thrombosis, and because of that there was collateral circulation actually going to the heart through the venous system and the hepatic venous system. A little quick summary of other lesions. Here's an interesting case. This patient had CA esophagus, and you can actually see this focal area in the liver which is showing differential attenuation. This is some form of radiation-induced steatosis and hepatitis because this was the field of radiation. Like even in patients with lung cancer or breast cancer, you can have these non-territory-based areas of abnormal signal even in the liver if you have radiation hepatitis. This is a common condition which is the von Meyenberg complexes, which is biliary hamartomas. Here's a patient who's had a splenectomy, and on the CT there was this differentially enhancing focal lesion along segment 6 of the liver, which was actually an ectopic spleen because of splenic rest tissue due to this patient with splenectomy, not to be mistaken for a focal liver lesion. And finally, this was a lesion which was actually picked up on ultrasound. It was a dropped calculus forming a perihepatic abscess. You can have issues in patients with Budd-Chiari syndrome or constrictive pericarditis or congestive heart failure where you can mistake these lobulations in the liver as focal lesions. As long as you're aware of these entities, I think you will have a degree of pragmatism in your day-to-day practice to be able to distinguish what are the real lesions in the liver from the pseudo lesions in the liver. Thank you.